Okay, we're live now, Beach.
Thank you very much indeed. Good morning, everybody, to January's board meeting for Herefordshire and Worcestershire Health and Care Trust. Welcome to all board members in the room and to everybody who's joined us live, as well as those who are on the screen. Debbie, Lisa, thank you for joining us. We'll get started with apologies if we have any to note. I know Simon Adams from Healthwatch has sent his apologies. I don't have any others to note if anybody's aware. Okay, thank you. And you'll all know, but it's worthy of reminder in respect of declarations of interest. If any of you have any changes or circumstances, then just speak to the office of the CEO and the chair, and they'll make those amendments and declarations as necessary. If there are any that anybody needs to comment on now, please feel free. Good, excellent. We'll move on to, for many of us, what is our favourite bit of the agenda, which is the patient experience. So over to you, Natalie.
And I'm delighted to introduce Lisa, who's joined us this morning to talk about the infant feeding team and what they deliver, and she's got some patient feedback for us. So I'll hand over straight to you, Lisa, if that's okay, to introduce yourself and your presentation.
Yeah, that's great. Good morning, everyone. Nice to meet you all. Sorry I couldn't be with you in person. I will try and share my presentation. Will this let me share it? Sorry, with this
It should do, yeah.
Okay, it's just loading up. Can you see that on the screen now? It should say infant feeding team. Yeah. Okay, that's great. So if you can't hear me at any time or the connection goes wobbly, just please let me know. And I can obviously go back a slide if you haven't seen it. This is really brief and I put this together quite quickly, but I'll just introduce myself. So I'm Lisa Dare. I'm the infant feeding team leader. And my background is I'm an adult nurse, I'm a health visitor, and I've trained as a midwife previously as well. So I'm also team leading with Becky Simmons, who couldn't be with us today, but I'm doing this presentation on behalf of both of us. And the infant feeding team sits within the Children and Young People and Families SDU, which is within the 0 to 19 years public health nursing service. And I'm really pleased to be invited today to discuss the patient story. So first of all, I think some of you might be wondering why breastfeeding is so important. We know it's it's a high impact area. We know it's a public health priority, and actually it's a really big responsibility in terms of public health to increase breastfeeding rates and to support women who want to breastfeed. So we know, just to give you a bit of context, breastfeeding saves lives. We know that hospital admissions are reduced for babies who are breastfed. The risk of sudden infant death syndrome is reduced. We know that breast milk is packed full of immunity boosting properties and ingredients that help to protect against infections and to help the health course across the life span of babies and children and adults. We know that the benefit of breast milk have impact in the long term, even considering overweight, obesity. The risk of diabetes is reduced for babies that have been breastfed. And we know that even for women, there's benefits as well, big benefits in terms of reduced risk of breast and ovarian cancers. We also know that breastfeeding helps to support the brain development and healthy brain development of babies, which is so important, as well as building those close and loving relationships and helping to support attachment. So just to highlight the issue that we're facing and that we have been facing for many years in terms of breastfeeding is being undermined by the inappropriate marketing of breast milk substitutes. So the formula companies, we need to help protect parents against this sort of aggressive marketing to make sure that they're given the informed choices to be able to feed their babies however they choose to. We know that 8 out of 10 women will stop breastfeeding before they want to. This isn't just a local issue, it's a national issue. We know that England, compared to, other countries across the world, especially Scandinavian countries, we know that we're really low in terms of breastfeeding rates, especially when we think about the age, babies are when women return to work. We know that breastfeeding drops significantly. So I thought it would be useful just to share a really short video from UNICEF, which will probably explain what I've just said a bit more clearly for you. Just please remember, if you take nothing away from this presentation, feeding, for babies is so important. Breastfeeding is so much more than just nutrition. Hopefully the next slide will work and the video will work for you. Okay, hopefully you found that useful, and I won't go into this in too much detail, but just to mention, Baby Friendly Initiative from UNICEF is a programme that we are following as a trust and as a 0 to 19 years service. So we have got UNICEF accreditation. We achieved that last year. We got stage 1, which is a really big achievement for us. We're aiming for stage 2 this year. It's a gold standard in terms of making sure we're supporting those families who need us, and that we are, trying to improve and increase breastfeeding rates and offer families the support that they need. Just to mention, as part of the UNICEF programme, we have had to, one of the roles that we needed to fulfil was the Baby Friendly Guardian. And I'm really pleased to say that Sue Harris, who I know is in the room with you, is our Baby Friendly Guardian, and she does an amazing job of raising the profile of breastfeeding and supporting breastfeeding at those, those bigger meetings, at those wider discussions, at those, wider, bigger policies in terms of anything really that could involve, breastfeeding and supporting women to breastfeed. For example, returning to work, initiatives that are happening in the community. And again, if anyone's spoken to Sue, I'm sure that she's told you about her role and how important it is and how much, we really do appreciate you, Sue. So thanks so much for doing that for us. Okay, so just moving on to the next slide then. Just really briefly, just explaining the team. So we are a county-wide team. The infant feeding support workers are band 3 infant feeding workers, support workers. We have just over 3 whole-time equivalents across the whole counties. That's 7 people at the moment, although we are struggling with sickness and staffing in the team. We offer home visits for babies below 6 weeks, and sometimes we go out as early as day 1, day 2, when women come home from hospital. We offer, if anybody needs a visit, they will get a visit from someone in the team. We try to be as responsive as possible. We can sometimes even visit the very same day. We know that, when women need that support, they need it quickly because they do struggle, and we don't want people to feel that they're struggling at home with their baby. We facilitate breastfeeding groups across the county. These are called Breast Buddy groups. We have Breast Buddy volunteers. Since September, we're onboarding those volunteers ourselves. And also Kate Richards, again, who I know many of you will know, has been really helpful in helping us to get those volunteers onboarded. We work closely with health visitors and midwives, and we accept self-referrals from mums as well. Quite often, referrals are coming at 2 o'clock, 3 o'clock in the morning to our email address to say, really need some help. Please, can someone come and see me? And again, those are picked up as soon as possible. Obviously, that comes with its own challenges. Working across the county, working in rural, for example, Tenbury is so different to inner city Worcester. Again, the team cover where needed, and we have such an amazing team of really passionate people to help, support breastfeeding. And also bottle feeding if needed as well. We support whatever's needed for infant feeding. Leadership within the team involves the education of all the 0 to 19 year staff. Again, that's the UNICEF training. That's making sure that we are all abiding by the code of the breast milk substitute. So, to make sure that we are not promoting any formula or teats or dummies or anything like that on any of our posters or, any of our paperwork. And we're working towards stage 2 UNICEF accreditation. Okay, so we're coming on next to the patient story. So I spoke to Sarah just last week, who had her baby last year. Now, Sarah had quite a complex labour. She had a low-risk pregnancy, but ended up in quite a long, lengthy labour that ended up in difficulties, and she ended up with an emergency C-section. She came home just the next day, and she was obviously very sore, very almost traumatised really by what she had gone through with that difficult process. Although thankfully, baby was absolutely fine and healthy. So she wanted to breastfeed, and she'd intended to breastfeed, throughout her pregnancy. But she really struggled. She struggled. The baby was quite sleepy. The baby didn't want to latch. She was worried that baby wasn't feeding enough. She did have the midwives come out to her, and they were a good support. But Sarah told me that the midwife, she didn't see the same midwife twice, which was quite difficult in terms of building up that rapport. So she did get referred to our team because she was the baby was on a feeding plan. The baby had lost a lot of weight. We know that when babies lose, for example, up to 15% of their birth weight, they will have to be rehospitalised, which is what we really want to avoid at all costs. So when babies do start to lose weight, if they go over 10%, then they do get referred to our team by the Acute Trust. So the infant feeding team came out to Sarah, saw her at home. They supported her. She saw 2 of the team over sort of a couple of weeks, really doing about, I think, 3 or 4 home visits. And Sarah said the support from the team was absolutely amazing. She said that she couldn't believe how much they helped her. They gave her time. They came into her bedroom because at that point she hadn't left her bedroom. She was so sore. She wasn't really able to get up and mobilise. She was really trying to keep herself and her baby, away from distractions. But Sarah said the team came out. One of the infant feeding support workers sat with her for a really long time to just discuss, feeding and to explain her baby's behaviour, that actually a lot of it was normal, that skin-to-skin contact would really help to encourage breastfeeding. They talked about positioning, attachment. We have knitted breasts that we do demonstrations on, and also dolls. So the infant feeding support worker explained the positioning and attachment really, really simply to Sarah to try and help, because we know that as much as it's easy to read when, in terms of pregnancy, when you've got a real baby there, she was quite a small baby, and it was difficult, obviously, for Sarah to latch her. So the team helped to give that support. Sarah said that the group was a life changer for her. So as well as having actually the team come out to her home, she came to the Breast Buddy groups, and she continues to go to that group now, even though her baby's over a year old, which is fantastic. So, and that is what we encourage at the group. So obviously Sarah was new to the group to begin with when her baby turned 6 weeks old. And she needed that support from other people, more experienced people in the breastfeeding group. But then obviously she's now progressed, and she's offering that support to other people. And we're really pleased that Sarah's actually expressed an interest in becoming a breast buddy herself to give something back to the community. And she's, even when she returns to work, she's going to be having that day off a week to be able to help support at that group, which is fantastic because, again, that peer support is so important. So just to mention what Sarah said, so she said the support was just amazing, the time that the team were able to give her, and the rapport that she was able to build up with with 2 of the team members was just fantastic. She felt that she could trust them. She felt like she could explain how she was feeling. We know that, especially in the early days of a baby, it's life-changing in terms of, exhaustion, obviously recovering from, major abdominal surgery, which an emergency C-section is, and also worrying about her baby, gaining weight. That was a lot going on there. So there's a lot of emotional support that's also needed for these mums and their partners as well. So she really appreciated the consistency. She really appreciated, the people in the team just being there to be able to reassure her really and explain that normal newborn behaviour and what she needed to do. She said that reassurance was really important to her. And she said that the best piece of advice that she was given was just to take it one feed at a time. So it's easy, in those early days to worry about what's happening. Feed is not going well. It's never going to work. How am I going to, get through this? And she said that actually that advice was really, really key for her. And she did just take it one feed at a time. And in those early days, something just clicked. And actually, she said, it was with the support of the team that she got a really effective latch, a really good feed. And from then on, things just went in a positive direction. She said that group is the one thing that kept me going. It's for that social interaction as well as having that support from the team as well. So really the team are there to facilitate and to offer any one-to-one support that's needed at the group. But the group itself is so supportive, in terms of, reducing isolation, getting people out, getting people socialised and making those connections. We know people that have made lifelong friendships from, baby groups and breastfeeding groups. So I did say to Sarah, obviously it's great that, all the things that she told us in terms of the quality that she received and the care that she received. But actually, if we could wave a magic wand to make things even better, what would she suggest? And she said, she wishes there was more of us, we do struggle to cover the whole county. Sometimes people do have to wait for a visit when there's not enough staff in. If it's days off, everyone's quite part-time. It's quite difficult. We work Monday to Friday. She said it would be great if we could offer home visits for older babies, which at the moment we can't. More touch points as well. So actually, if people haven't contacted us in the early days, but maybe need us later on, they don't, they're not really encouraged to do that. Although they know that they can contact us, if they haven't built up that rapport, we are not really contacting them. They don't have us in mind as a point of contact really. So that's something to think about. Better digital engagement. And again, I've spoken to Ellen about this. So, we know that we're behind the times in terms of digital engagement for families, being able to, to self-book onto things in terms of, their appointments for health appointments for babies, their development reviews, within the 0 to 19 year service. I think there's something that we can do around potentially a newsletter or social media, to get more followers so that we can send things out and try and reach people and just, raise our profile a bit more in terms of digital engagement. So just quickly then, I just thought I'd also include some care opinion because we rolled this out in the autumn last year and it has been overwhelmingly positive. So 100% would recommend the service. And there's a link if anybody wants to go and read these stories. I'm not going to read out every one. Obviously, you can see on the screen. These are just direct sort of copy and pasted from the care opinion stories that have been published. And I think it's really important, really. There's some themes, about helping to build confidence, supporting people. Again, about being kind, being, empathetic. And actually just trying to be there as needed, really being responsive. We're really trying to be a proactive service, not reactive, and we're trying to be there. It takes a lot for somebody to ask for some help. So although we do send the welcome text, as soon as somebody comes out of hospital and they're breastfeeding, that text can get missed. So we really do need to try and, and be proactive. It takes a lot, like I said, for people to ask for help with feeding. So that's, part of our goals going forward, really. Ongoing plans then. So we have been funded to give some antenatal education and we know that this will really help to try and improve those breastfeeding rates. We know that in those higher deprived areas, the breastfeeding rates are really quite low compared to national figures. And we know that there's a lot of work that needs to be done there. So antenatal education, talking about benefits of breastfeeding, will really help that. That's what we're planning for. We want to, obviously, like I say, help those higher deprived areas. We're offering more sessions for colleagues, so health visitors, obviously within the service, so that they can support families as well. We're trying to put together a complex feeding clinic in the community so that, again, it meets those goals for UNICEF for our stage 2. And we know that GPs and GP surgery staff will need training. And that's something we're talking to our commissioners about as well, because again, we all need to be saying the same thing to these mums. You know, if they're on feeding plans, if they're struggling to feed their baby and they go to a GP and they give completely different advice, that's, you know, that's not fair for parents. We need to all be saying the same thing, really, given the good evidence-based information. We want to also maybe explore the way that we could support staff within the trust. So as part of the wellbeing offer. So maybe, you know, we do know outside of work, there's lots of staff are parents, lots of staff have either breastfed or, you know, tried to breastfeed and maybe have stopped before they wanted to. You know, or are maybe going to have future pregnancies. There's something that can be done around that to be able to, you know, and a lot of the people that work at the trust are Worcestershire based. So we want to make sure, again, that we're reaching out to as many people as possible and offer support if needed, whether that's a debrief, whether that's, you know, a conversation, or however that might be. Again, we're going to keep working towards UNICEF full accreditation. So stage 2 this year, then hopefully stage 3, and then we'll be going for which is the highest one, stage 4. And again, just continue to raise the profile of the team. So we've been really lucky. We've had Ellen come out to the breastfeeding group. We've had come to a team meeting. Obviously, we've got Sue as well on the exec board, who is flying the flag for breastfeeding. So hopefully, you know, all these conversations are taking place, and hopefully after today, again, you'll understand, you know, the importance of why breastfeeding is so important. But also just wanted to say it's not just obviously for breastfeeding babies. You know, as part of the infant feeding team, we support all families. You know, feeding is such a personal issue, and it's a sensitive issue, and we want to make sure that, you know, that we support moms to achieve their feeding goals. As long as they've been given the information, they can make their informed choices. You know, that's what we support, so that obviously we can hopefully build these happy, healthy babies. Okay, thanks for listening. Mine and Becky's details are on there if anybody wants to email us with any follow-up questions. But I will stop sharing now and obviously welcome any questions that you might have.
That's brilliant. Many thanks, Lisa.
Yeah, Debbie. Oh, sorry, I was going to say, Debbie's got a hand up.
Thank you. Really good presentation, Lisa. Thank you. That was really interesting. The only thing I would ask is, you said early on in the presentation that 8 out of 10 women stop breastfeeding before they're ready. Is that purely down to the aggressive marketing? Okay, and also my second question is whether there's a bit of work needed around the continuity of having the same midwife come out to see the parent, because you'd said that obviously she struggled with that, and that potentially might help parents who aren't under your team.
Yeah, so just to answer your question then, so your first question about the reasons why.
Sorry, Lisa, 1 second, Lisa, sorry.
Yep.
Before you answer, I guess, Debbie, we can't answer the second question about midwives because it's not our service. So just really mindful that
Okay.
we talk about our services our trust delivers.
Yep, that's fine. Okay.
Thank you.
So the reasons why women stop breastfeeding before they want to are multifactorial. It could be the fact that they're feeling pressure from the community, they're feeling pressure maybe from older, you know, generations or family members. It could be there is a high percentage due to the, you know, to the aggressive marketing. We know that on social media, you know, algorithms are targeted. These companies know when these women are pregnant, and they do start bombarding them with adverts from an early stage. There's underhand marketing. For example, they sponsor care lines, you know, phone us for your, you know, advice around your baby's feeding, or actually, why don't you try this formula? You know, all of these are really, you know, again, it's not right, and it's not fair that these parents are subjected to that. So that's why we're just trying to make sure that we get all that information out there, and to try and make things easier. So, for example, even returning to work, you know, it's part of employment law that women should be allowed to pump if they're breastfeeding, to be able to express their breast milk, to have a fridge to be able to store that in. But we know that doesn't happen for a lot of women, you know, and again, that could be the reason if a woman's returned to work and she thinks, actually, how am I going to manage this? You know, again, that can be a reason why. So the reasons are far, you know, many really, but we do know that the aggressive marketing is something we really need to be careful of.
Okay, thank you.
Sue Harris and then Sue Brooks.
Yeah, thank you. I mean, Lisa, say it's a real privilege to be the baby friendly guardian. I've met most of the volunteers. I've been out to a number of groups, and I suppose I just wanted to reflect at one of those groups about a year and a half ago. I met a mum who had tried to breastfeed many years ago and was unable to carry on. As you say, the reasons were multifactorial, but she was really disappointed. And then this time with her next child, she was able to breastfeed, and she said absolutely it was because of the peer support, because of the expertise of the team. So to hear that was really, really pleasing, and really shows what you do makes such an impact. I suppose it's how do we as a board help promote the service, because a lot of the volunteers, as you say, are people who've experienced the service who then go on to volunteer and want to put back that peer support. So there's something about raising the profile. We've taken the onboarding of these volunteers in-house, so to try and support the team to get more numbers through. And these sort of volunteers aren't going to stay with us forever, are they? I mean, I met one person, she'd been with us 5 years, which I thought was pretty exceptional, but normally probably 1 or 2 years. So there's something about how do we help you, Lisa, keep this live and, you know, and dynamic, because it's a really exciting space when you go out to the groups and meet the individuals.
Yeah, and it's really great. Our breast buddies are so supportive. There's such a good help in the groups. And like you say, the lifespan of a breastfeeding volunteer is quite short, because it tends to be when they return to work, they just don't have the time or the energy to be able to give that time back to us. Like I say, Kate Richards has been really helpful in terms of helping to onboard, but I'm sure there's more conversation that can be had to see about making the process a bit more streamlined in terms of the paperwork. How much, how many details they need to give in terms of, health information, occupational health, all of that, that would again really help us if we could reduce that, because we don't want these women to have to be jumping through hoops to be able to become a breast buddy. They give so much support. We offer the in-house training to them. But again, I'm sure there's stuff that we can make better as well, which we could have a conversation with outside the meeting would be really helpful.
Yeah, thank you, Lisa. Let's do that.
Thank you very much, Lisa, for that. This question might be for you or for Sue. Within our own trust, how supportive are we of allowing people who come back to work and want to carry on breastfeeding?
This is the conversation that Lisa and I were having. I would have thought at the moment we probably need to do more about wrapping this team's expertise into some of our wellbeing, and that's what we want to explore. And that's why we were talking about this earlier, because I would probably say, if we were being honest, it's probably quite variable. But Lisa, I don't know if you've got a view.
Yeah, I would say that a lot of the from my experience, people are obviously able to express if they need to be able to store their milk. I think again it's different across the trust in terms of those rooms. We don't want people to be shoved into a toilet to have to express their milk. That's not hygienic, that's not nice for anybody. So it's something we need to think about. We need to think about being more welcoming to staff for breastfeeding and for pumping, but also for our visitors. So it's something to think about. Our waiting areas, actually, are we welcoming to these breastfeeding moms? People really struggle in the early days to breastfeed in public. Only takes somebody to look at them the wrong way or say a comment that will completely just put them off, from breastfeeding, and that's so unfair to that baby, and to that mom. So again, it's something that we need to think about making all of our spaces welcoming for breastfeeding as well across the trust. Just to mention, I was talking to somebody recently who was actually a service user, but was also a GP. She was saying when she returned to work after her first baby, her GP colleagues told her that actually she couldn't breastfeed any longer because she needed to give all of her time to to her appointments and her patients that she was seeing. She had to herself dig out the HR policy to find out that, it is written in employment law. It's a human right to be able to give, to be given the time. She said herself, she just shut her blinds and, and kind of pumped in her room when she needed to. But again, for those women that aren't aware of that, this is, that was a GP surgery. They, should have been aware. But, we know there's so many different employers across the county. And it's something that, again, we need to raise awareness of, really.
Lisa, thank you so much for joining us today. Thanks for taking us through that patient story about Sarah and her baby, but more specifically, just talking about your service. Clearly, it's so valuable. And we're very grateful for all the things that you put on your wish list and the magic wand. Of course, it gives us all food for thought, and we need to take those things very seriously, and we will. But for now, please do thank all your colleagues. Thank you to you for all the efforts, and keep up the hard work. Thank you.
That's great. Thank you for having me. And like I say, my email address is at the end. If anybody has any questions or comments or wants to talk to me about any of the issues, feel free to. I could talk about breastfeeding all day, but I know you've got more, other pressing matters to talk about. So I will leave you now. But thanks ever so much for inviting me.
Thanks again.
Have a good day.
Thank you.
Bye-bye.
Thanks. Great. Before we move on to the rest of the agenda then, folks, just a quick reminder to those that have maybe joined on Teams or are watching this live. The rest of the meeting will be a meeting for the board, and certainly it's available for those that are watching to watch and listen. Questions will be invited from just the board members themselves. Okay, let's do some formalities, please. Matters arising and the actions log. I don't have an attachment. I think there weren't any actions that we took away from the last board meeting. And unless there's any other matters arising, then we'll sign those off as well. I note that there are no questions provided for the board from members of the public for this board meeting. And so we're on to item number 7 and number 8 on diligent, which is the chair's report. What a fantastic, but also very difficult couple of months it's been since we had our last board meeting. Of course, one of the key things, we've been through the winter period, and that has presented all the various challenges that we've had to deal with. But I just want to offer my thanks to everybody, staff and leadership, who have shown such focus around making sure our patients are being cared for extremely well through that process. Obviously, I must mention that working with our partners has been fabulous through that process in order to make sure that we can maintain services at the standard that we wish to. So thank you for everybody, including system partners, for all the efforts that we've made. The strategic focus that we've put in, we just released our new trust strategy. I think that's starting to bed in really well. This week alone, we've started to produce collateral, and Sue Harris and her team have done great work on that. So to staff who are watching, please do take the opportunity to pick up on the leaflets that are around and the literature that we produce that talks to the staff, to the trust strategy. There's some really good stuff around, and please do ask questions on items that you want to. I'd like to formally thank Sue Hinks, who's offered to stand in as interim chair for the People, Culture and Committee. Thank you, Sue. Obviously, it happens because we've had a retirement from Vina Allison. So I'd also want to formally record our thanks to Vina and all her efforts that she'd made in her time with us. The best bit about the job, I have to admit, being interim chair, has been getting out and about a lot more, and I've really enjoyed it. The highlight for me, and you're welcome to read my report about where I've been, but the highlight for me was visiting Tenbury Community Hospital on Christmas Day. The team were in such good spirits. That it's clear that it's a really challenging job anyway, exacerbated by the fact that during the winter period, we've got some very ill people, unhealthy people who are in our care, and our staff do a fantastic job of looking after them. And I only saw just the Tenbury Community Hospital gang, but I know that they are a reflection of all of the staff that we've had caring for our patients, especially over the festive period. So a personal thanks to the gang at Tenbury for hosting me, but thanks to everybody who worked over the Christmas period and gave such quality care to our patients. The team have done a great job of putting some colourful pictures in the report, which you'll see.
Your jumper.
If it was a 3D photo, you'd see that the carrot on my Christmas jumper actually protrudes quite a distance. But anyway, I won't do that anymore. I've had the pleasure of sitting with the ICB leadership as they've been trying to formalise and confirm the roles that they've been filling and helping them with the recruitment. So as I understand it now, the enlarged cluster ICB board has completed its recruitment process, and I have the privilege of sitting on some of the non-executive members' interview panels. And I'm very grateful to Krishni Waring, the chair of the cluster, for inviting us to take a part in that. But also importantly, there's a really, now that they've got their leadership in place, They've got a clear focus. We were at their first board meeting last week, Ellen and I, and certainly our participation in that alongside all our partners is going to be critical to the ICB success. I'm going to end with celebrations, and of course, again, as my report shows, there's some great effort being made by so many people. The CARES values are really, really important. We shouldn't diminish how important they are. And actually, whilst we don't talk about them every day, it's clear that our staff, so many of them live and breathe them through everything they do. And whilst we're specifically recognising on this report a handful of people, what I've found in my visits is that actually there's tons and tons of people I'd love to give this prize to, because they are really, really living our values. Specifically in November, the catering team and Jade Wells, both deserved winners of the CARES Value Prizes and certificates. And in December, the Cityside Neighbourhood team and also Ben Sturrock, an ACP down in Pouch, all deserving winners. So thank you very much. And I think I'll finish by just thanking staff more broadly. Again, my visits have really given me an amazing insight into such a fantastic job they do and such effort that they put into caring for our patients. So thank you. Does anybody have any questions for me? If not, we'll pass over to Ellen and the Chief Exec's report. Thank you.
Thanks, Beach. So my report, as you know, includes a bit of a summary of local trust issues, local system issues, and a few national updates. So a few things just before I launch into a bit more of the detail of the report that I would like to bring to the board's attention. So there was a huge amount of work that's been going on the planning round submissions, lots of technical detail required. Obviously, board members will be pretty much up to speed with some of the work we've done in our more informal development sessions on how that's been going. But we completed the interim submissions and we have now got some feedback from NHS England, and we were awaiting that when I did the report, but we've had some high level feedback, which is enabling us to shape the final submission, which is due in mid-February. We've also had, since we last met, the further junior doctor strike. I'm pleased to report that we went through that reasonable stability, and thank you to the colleagues who kind of stepped up during that period. And we're also going to mention something about the Mental Health Act, which, as many of you will know, has now received royal assent. So I'll start then with some further changes to the board. Obviously, we've been in a bit of a period of change for some time, but I'm pleased to have formally announced that Gemma Arts has been successfully appointed to the position of Director of Patient Experience, Digital and Innovation. And you will get to meet Gemma this afternoon in our informal session. She's going to hop in this afternoon. Gemma brings a wealth of experience, both as a clinician and in programme leadership and in digital. So I'm really looking forward to welcoming Gemma to the organisation. We think her start date will be around about the 16th of March, but just still working through the finer details. I've already mentioned the planning round and the industrial action, so probably not a lot more to say on those points. So the next point I'll just draw to your attention is that we had a monitoring visit to Jenny Lind ward on the 27th of October, and we've now received the formal report following that visit. So there was some really positive feedback. Patients said they felt safe and that staff would go above and beyond. There was, however, some actions to how we document some of the care plans and risk assessments to ensure those are truly individualised. So we are continuing to work through those, and the plan is that all actions will be complete by the 1st of April. You've then got my update of some of the visits that I've been doing, as well as visiting the infant feeding team in person, which I have to say was an absolute delight, because a morning spent with small babies, there's no problem with that for me. But I also joined one of their team meetings and didn't get an opportunity to mention it when Lisa was still here. But we have taken away from that the point about the patient booking. And there are some things that we'll be able to update on soon on the kind of timeline leading towards that. And there's a national programme now called Wayfinder that you'll hear a bit more about, that will eventually enable us to book and have integration with the NHS app so that patients will be able to keep that all in one place. But just to trail that, it'll be something for the future. But it was quite exciting, I think. We've also got an update then, moving on to some of the system issues, the update on the Herefordshire SEND review. And also since then, we've also heard a public feedback that Herefordshire has been rated as good by Ofsted for their children's services. So that's a huge achievement, actually, considering the journey that Herefordshire has been on. And obviously, I've offered our thanks and congratulations to Paul, the Chief Executive of Herefordshire Council. And it's probably worth just noting that, of course, we had an input to some of the areas in that review, particularly around some of the issues we flagged here about SEND and neurodiversity. And there's definitely learning about the fact that we've seen a different position in our Herefordshire services versus our Worcestershire services. So the challenge that I have put to the team is, how do we apply that learning across? Because we're in a much better position in terms of waiting times, and probably our offer in Herefordshire has more of the features you might describe as a sort of neighbourhood health model, where we're quite well integrated with schools. It's a more of an integrated pathway. So I think there is some learning we can apply across there, which is just a positive point to draw out. And we'll probably come back to that actually when we come to Scott's operational report, and you'll hear about some of our waiting times challenges. Aside from my kind of visits to our services, I also visited the newly revamped Lee's Place in a new location in Hereford city centre, actually just before Christmas on the 19th of December, and heard about all their plans that they had over the Christmas period to support people. And also in another kind of neighbourhood health example, to use that term, we now have a member of our team working in a joint clinic with members of the county council, delivering care to people actually in that venue. They've set up a small treatment room downstairs. So that's really going out and meeting people where they are in the community and supporting some of our most vulnerable people that we serve. So I was really encouraged to see that progress. And I know that's been very much something that the local team have initiated. And I had feedback that the local neighbourhood health teams have been very supportive to the setup of Lee's Place, had dropped off things they'd collected themselves. So it's really great to see that really positive local connections being built to support some of our most vulnerable people in place. I'll just mention then briefly a couple of national updates. So Mental Health Act. So we will have to work through the implications of this, but it is a long-term piece of work. So I'm sure you'll hear more about that as a board as we progress that work, and we'll bring that and share that. But it's just worth saying that sort of milestone has been passed. We also are aware that there is an independent review into particularly ADHD and autism. So we will stay abreast of that and obviously respond as that reports in due course. And then there's also the work which comes under the heading of the Community Mental Health Services Report. You will be aware of an update we brought to the board. I think that was back in September, about the work we're doing in response to that. But we will need to think about how we update and feedback on the work that's been going on. So Scott and I have discussed when we might bring that back to the board to give you that update and assurance, but just to flag some of the national things that are happening in that space. So that's it from me, and I'm happy to take questions on any.
It's not really a question, but just a comment to both of you that it's wonderful to see all these visits and to read all the intel that you're getting. So I know that when you've got busy diaries, it's hard to fit things in, but I think it's really, really good what we're learning from your report. So
thank you.
Stunned everyone to silence.
I will, on behalf of both of us, actually, just also mention, if I may, I forgot to do so earlier, that Sean Tudge has joined us. Congratulations, Sean. He's joined us as head of the CEO and Chair's office, which is going to be quite a critical role in not just sorting us two out, but just more generally around a number of different things, which will become clearer to all of us as time goes on. But certainly visits, as you mentioned, that is an important part of that. And how do we get smarter and more focus on the areas that we wish to go and see, and what sort of things do we want to glean from them, as well as which areas do we want to support them in terms of improving or developing. So welcome, Sean. Sorry, I should have said that earlier. Thank you, Chair.
And I'll just say one further point as well, which is one of our goals, and we will talk to members about this at some point soon, is that we also want to up our presence around what I would call kind of hospital at night, so the out of hours periods. I have to confess, get BJ out of bed far too early when I misread my diary. I attempted to do such a visit on New Year's Eve. So we did end up not quite achieving that due to a bit of a breakdown in communication. But we did meet some of the night staff coming off shift.
We did, yeah.
And it was already informative to meet and hear some of the feedback and hear the experiences of some of our colleagues. We spoke to one colleague who gets a bus and a train to travel to our site to work nights for us in the Elgar unit. And I was really struck by how we don't always see and understand stories of some of our colleagues. And he had just come from Ghana just 3 years ago, and the sort of impact that he was finding with juggling all of that. And that was just quite a short conversation. So I definitely was left feeling we need to do more of that and ensure we are visiting in the whole 24-hour period, which is how our services are delivered. So as we mentioned, I've tasked Sean, amongst many things, with a more coordinated visit programme for all of us. But one of the things I will ask, just to trail it now actually, is that you offer a couple of those out of hours slots so we can get that presence for all our colleagues throughout the 24-hour period.
Excuse me, Chair, can I put that as an action?
Yeah, that's a good idea. It's an action unusual. Thank you.
To organise us.
You'd like an action or yours?
Yeah.
Good, good. Okay. There's no other points. We'll crack on with the agenda. The next point was to approve the minutes of the last meeting that was held in November. Were there any comments, corrections, or questions regarding those minutes? Or if not, we'll take them as a true representation of what we discussed. Great, that's all signed off. Thank you. And I went back, didn't I? Didn't know why I wanted to tick it. I hadn't ticked it off. That's why I went back to it off. Right, over to the patient experience report.
Okay,
And that's with you, Sue.
that's great. So, yeah, a really energising read, I felt. So I just wanted to pick out some areas which I suppose just shine a light really on some of the work that's happening across the organisation, which is around that improving experience our services, because some of this is not invisible, it isn't as well known, just because it's sort of gone into the warp and weft of the way we do things. So I suppose I just wanted to note we continually see an uptick in people joining some of our key forums, whether that's the community engagement panel, the youth board, or as we heard earlier, the infant feeding team. So, you know, again, that thanks to the volunteers that come on, they give a lot of time, a lot of their expertise, and so it really is appreciated. We got an equality advisory group that wraps around a number of our key projects in terms of offering advice on things like equality health impact assessments. This is a group of individuals who identify as having protected characteristics. So we take early projects just to start to kick around. How would we need to think about this? What might we need to consider? And then obviously they do some of the more formal critiquing of the programme's work as they develop. So it's just to say that's a really important piece of work for us. And they've done some great work around the carers checklist. So we know that we've been looking differently around discharge. We've had some beds reduction and getting carers into a place where they feel ready in terms of their loved one coming home. What does that look like? We co-produced that with carers. We did that work with voluntary sector colleagues, and it was to ensure that carers were aware of the process of discharge and to make sure that we'd got some really good support officers in place or places they could be signposted to get that ahead of the person coming home. It's early days in terms of making sure that that's systematically used in all of our pathways, but we're working with Scott's team through the community hospital transformation work to make sure that that becomes embedded. I suppose I also wanted to flag there's been a piece of work around children and young people's mental health and wellbeing services that's been talked about in the system now for at least 18 months. And it came from feedback from partners as well as parents, as well as children and young people themselves, that it was quite complicated to know where you were going for what services. And a lot of the time it was pushing people towards CAMHS and probably not appropriately. So we did a piece of work to say, okay, what does the broader pathway look like? What are some of those earlier interventions? And how can we design this in a way that it's easier to navigate to get people into the right services or support structures at the right time? So we've had Ellie J. I'd like to thank Ellie, who's been working on this for a while now with system partners, and it's now been published. We'll be looking to launch this to say it's a system endeavour, but we've sort of called it our Children and Young People Mental Health and Wellbeing Roadmap. And it very much has two elements. One is professionals, primarily general practice. So we've done a lot of work co-producing how that looks and feels for them. And then there's a public facing element, and that's really, again, being road tested with our youth board, with the youth cabinet over at the council. So there's a lot of work in this space about checking and balancing. Is this going to do what we need it to? But hopefully it will simplify what's available for children and young people with mental health and wellbeing. What should you go to for what support, and to make sure then anything we do develop into that space, it's really clearly meeting a gap, or it's expanding and it's really clear then about, you know, which service you'd go to and for what. So I suppose we've heard again about care opinion. Wasn't it great to see that on the screen? I mean, it's still the highlight of my week on Friday when I get the digest, which gives me all the headlines. I suppose I just wanted to flag that we hadn't got that previously. We hadn't got a set of feedback from particular neighbourhood teams. So I've been doing some work with the teams around what does that look like. We're seeing the telephone calls and the writing in for those teams being stronger perhaps than some of our other teams where the feedback's coming in digitally. So we've had our first annual review to go under the line really. What sort of teams are getting what feedback and how and when, and how do we strengthen that? Where it's working really well, we're getting high uptake. How do we spread some of that learning? So just to pick up though, if you say that we've had 575 stories and it's got 31,000 views, I mean, the dissemination is really impressive. So just thinking again with how do we use that to drive quality improvement? We get very few negative stories, nearly all of it. Areas for improvement, but most of the time it's about wanting to say thank you and wanting to acknowledge the professionalism and compassion of our teams. So actually, again, trying to pick out some of those stories and think about how do we share some of that learning and use care opinion more effectively. A couple of final points really about the priority programmes paper, which we'll touch on lightly later. And just to say that we've got the patient experience being wrapped into the adult mental health rehabilitation, the work we're doing with pediatric therapies and nursing, real tangible examples of where we're going out, engaging early, continuously engaging through the process, and then bringing in that expertise around formal consultation as and when it's required. So that's quite a key bit of assurance for us around the table about that transparency around some of the changes we're making and how it's embedded in processes. We've had a lot of conversations at board around health inequalities. So again, there's some updates in the report about the work we're doing on accessibility specifically and health literacy. Quite a cross-organisational endeavour. So getting the accessibility information standard is taking cuts across a number of our executive portfolios, doing assessment on the focus of what we're going to do over the next 12 months. And then finally, I'd like to thank our public health colleagues. They've done some great work with us around giving us some more detailed analysis on health inequalities around, for example, severe and enduring mental illness. So again, building that in specific projects and public health supporting us. So that's really appreciated. That's all I wanted to pick up, Chair. So
Thank you.
Happy to take any questions. Or Natalie, if there's anything else you'd like to add on.
No, very comprehensive.
Colin.
So you mentioned in your report about the work of the Carer Oversight Group and its connections with the voluntary My sense is that there must be a huge cache of resource and support available in the voluntary sector, but it must be quite difficult to work with such a distributed set of individuals and groups. So I wonder, how do you feel, how effective are our current relationships, and is there more we can be doing?
We are very fortunate in Worcestershire, and I'm going to look down the table, but we've got Worcester Association of Carers, who've had a name change and now Caring in Communities, who we've worked with for a very long time, and then they are really the primary support structure for carers, and they do a lot of coordination then with the broader sector. So to some degree, they've made that entry point easier for us because they then pull in the other pathways. They've also been commissioned by the council to undertake the social care carers assessments. Then got a number of services which then wrap into our services. So in particular for mental health and learning disabilities, that would be where we'd signpost, and then they will then coordinate other organisations to wrap in and around as needed. Carol, you've been all things carers for some time, so yes. I don't think you had
that's probably what I'm saying. So I often go to the Carer Oversight Group. I also chair the Worcestershire Carers Partnership and the Herefordshire and Worcestershire Carers Reference Group that feeds into the ICB. So in some ways, I guess I am the connection, but and I used to work for Worcestershire Association of Carers. So I think we try and make sure everything links up, that we don't duplicate, that we pull in some of those organisations who haven't traditionally seen themselves as being carer support, but they are. And I think, carers would probably be one of the groups that feels slightly outside that, try and make sure we bring them in. So I think there's very good connections. I think we are very clear about all the different organisations providing carer support. The smaller ones sometimes have a little bit of difficulty engaging, but there's always ways of doing that as some of the larger organisations. I think Worcestershire Association of Carers are now Carers and Communities. They link into the smaller ones so that we get that feeding through. But yeah, there's been some excellent work. It's worth noting that there's a different provider of the carer services in Herefordshire, but they have in the last year set up their own carers partnership, and that we work, they have a place on the carers reference group across the ICB. So I'm looking forward really to seeing what's happening in Coventry and Warwickshire. Not that it's a world takeover, but there are common themes across carers wherever you are. So I think we're looking to build on that as well.
I wanted to add a thought as well, which is I met recently with, I'm going to call her Aunt Sarah Dugan in her new capacity. So Sarah is now doing some work with the Voluntary Sector Alliance in the county. And we had a really good catch up and about how she's got thoughts about how to take that forward, how we can engage. And she's actually offered to come and do a development session with us soon to talk about that work, which I would think would be hugely welcome. And I've actually just added to my list, Carol, that I think actually hearing more of an in-depth report of some of the themes that carers are raising that are important. We would really, I would really value that. I think probably the board would really value that. So we'll set that up within the next 6 months, I've agreed with Sarah, and that we can do a bit more of a deep dive into that, how that relationship is working and whether there's more we could be doing and how we can develop that further. Because I think, again, to sort of use the buzzword of the day, our strategic priority around neighbourhood health will really push us to think about how we're working together with the base. Building, of course, on the great work that's already been done in the district collaboratives.
Really comprehensive report. Thank you, Sue. And I never used to look at care opinion until recently, but now that I do, it's really interesting. And it's clearly so many good news stories in there that it makes you feel good, and we're really proud of the organisation. I wonder though how we can help care opinion or any other method that we have to encourage more learning. Not necessarily horror stories, albeit they do come to us, and of course people have other routes, complaints and pals, but I wonder, how do we encourage more ways of opinions being shared with us that we can actually learn and do something with?
If I can there's two things I think that are underway that will help with that. The first is that there's a functioning care opinion where actually you can develop a form, so you can So we are doing that with our new hospital at home team. So we've got our first care opinion stories, but actually we've now developed a form that will enable people to answer the questions that we really want, rather than just going on and saying, oh, the team were lovely and it was a great support. The form's asking specific questions. What was helpful? What would be more helpful? How did you find the technology? So specific things we want to understand, what's working and what's not, but people might not automatically think about sharing with us. So that will sort of drive the conversation down that what would be even better if, as opposed to just giving us some, which is lovely feedback, but you know,
of course, absolutely, absolutely.
And then there's a second piece of work about how we triangulate the wealth of information that we have from care opinions, friends and family tests, compliments, complaints, powers inquiries, and incidents, and how we can pull that together to get the best learning we can from it. Because at the moment they sit on separate systems. So we're looking at how technology can help us, because that will really then help them. Where are our key themes coming from people who use our or experience our services, and then what can we really focus on improvement wise? So they're the two things I'd talk about.
Thank you. And the response rates are brilliant. I did a quick comparison with other trusts, maybe of similar ilk to us, and what was really noticeable is that we are very quick to respond, and anything older than a few days has got 100% response rate. So that's great.
That's a really important thing about care opinions. It's the team directly, immediately responding, not the corporate powers team. Yes.
Thank you. There's nothing else. We'll move on to the performance report. It's over to you, Scott.
Fantastic. Thank you very much, Chair. So what we've got presented to you is the performance report, and this is an evolution report. Towards the end of this section, I'll just talk quickly about some of the things we're going to do differently as the report moves on. I do want to though start with talking about winter though, and just perhaps picking up on your point, Chair, and just really thanking all of our teams and all of our partners for the work that we've done together over the last few weeks. There's been some really complex and challenging issues, and we've really resolved those with a partnership approach, collaboration, and then the next stage is then going on and owning those improvements about what can we systematise. But working with Worcester Acute, Worcester Council, and our commissioning colleagues has really helped the system stabilise very rapidly this year. And from our services, our community hospitals, our interface services like Hospital at Home, and our neighbourhood teams have all really gone above and beyond to make sure we're getting patients to where they need to be, keeping them safe and giving them the best quality care. So it's really like to thank everybody in that space. Moving into the report, so this is currently structured around the 5 NOF domains. And these were all really important in terms of how we run our organisation and the impact we have for our patients and our communities. There's a couple of bits I want to pull out. So if we're starting with the access to services, I'm just going to pull out a couple of examples where the team's doing really fantastic jobs. So first of all, our community hospitals for physical health. They've done an awful lot of work around maintaining their flow under difficult circumstances, and they've done a lot of improvement work over the last 9 months. So from September to December 2025, they achieved 46 more admissions to community hospitals compared to the last year, and during that time we've actually got 46 less beds. And so that's really an example which has been driven by staff on the ground, understanding how we can do things differently, and really embedding that approach of how do we work with our partners to get patients the best possible care and to where they need to be. Equally, our mental health hospitals, working with John, there's been an awful lot of work about making sure we keep people as close to home as possible, to make sure that they have access to their families, access to the local environment, and there's been very few inappropriate out-of-county placements, only 1 over the last 8 months. Key component of that is the enhanced bed management model, which staff are really interested in terms of what's going to be happening with that going forward. And just in the public space, you want to provide staff the reassurance that we all recognise what a great job that service has done, and we will be looking at how we maintain that going forwards. Equally, we have to acknowledge where we've got challenges and where we need to focus our efforts. So within the paper, there's a table there looking at over 52-week target. Now, we have got big challenges within our children and young people services, particularly when we're looking in Worcestershire rather than Herefordshire. So as you can see, the position has deteriorated there. And the reassurances that I really want to provide board is that we are really taking that seriously. So we're developing 2 3-year plans with our commissioners, firstly around neurodiversity, and what that is doing is understanding is how by working in partnership, we will reduce the waiting list and get to the point where there's no over 52-week waits. We will be in a position to bring that plan back through board development in the coming months. But it is really picking up good head of steam, understanding how we're working with the independent sector, but also investment into our services to make sure that we're building capacity. So it's a really good collaborative piece. Equally, we're working around looking at community paediatric services. That plan will be ready slightly later. But again, we'll bring that to board at the appropriate time. Moving on through the report, so I'm just going to double back. I did this really quite critical bit there. So in terms of the NOF rating, which this report is built around, I just wanted to really flag we've been updated from Q1 to Q2, and that actually we've remained in segment 3. And the trust ranking is exactly the same, so 32nd out of 61 trusts. So there's been no real overall movement, no statistical change in terms of the scores. We are though building our longer term piece of work around how do we address the areas that are clearly in need of addressing. So we've talked about the access to services. The other bit I'd like to zone in and perhaps on is looking at people and workforce. So we've got a full plan around our staff sickness rates, which is obviously being overseen by the People and Culture Committee. That's a really critical piece of work as we go forwards. Equally, staff engagement is super important to us, that we have that we make sure we create the environment where staff are fully engaged and report being engaged in what we're doing as a trust. So that is a whole organisational piece of work. We know the importance of that in terms of quality of care, and I'm hoping for some positives to come out of the next round of the National Staff Survey. Finally, what I would just do is just note that the financial position, which is obviously part of the NOF, remains very positive, and we remain scoring highly in that particular domain. Final piece, just wanted to flag, and this moves into how the report's going to vary going forward. This report is going to become much more of an integrated performance report, driven through a data and analytics point of view. So picking up those core NOF metrics, plus a couple of other metrics that are important to board. And again, we'll do some co-creation work there during board development. There will also start to be a separate report looking at service transformation. Now, this is going to be incredibly important as we're going forward, particularly when we're considering the role of digital, the 10-year plan, looking at neighbourhood health. So the kind of things that you'll be seeing in there is the work we're doing around the community hospital transformation programme that Sue has already cited, picking up things such as opportunities around centralised booking and care navigation, looking at how we support as many, changing our model, working closely with the voluntary sector. So how can we keep as many mental health patients as close to home as possible? And again, continuing that work to reduce the use of anti-county services. But those reports will start to emerge over the next couple of rounds of board, as I say, with board involvement into what they want to see in there. So I think that's a bit of an overview of the paper. Obviously, happy to take questions, and also the multiple sections in here. There'll be colleagues around the table to draw in as well.
Thank you, sir. On you, Sue, and then Colin, please.
Thank you, Chair. Thank you, Scott, for paper and also the reflections. And it's fantastic to see the way the systems pulled together over winter. I know that every winter is different, but sometimes it feels like every winter we are reacting rather than, So my question would be, is there an appetite now? Because you talked about the system working together and all the fantastic work that is being done. Is there now an appetite for a system reflection on lessons learned that we can pull into forward planning so that every winter we're not reacting, rather we have things in place, strategies in place that would help us to be able to do better so that we're not here every winter getting new plans.
Yes, it's, as our chief exec reminded me in the heat of battle over my shoulder, that this is totally predictable and happens every year. So it was, it was very timely. It was, I think absolutely yes. So I've been in the system in various roles and organisations for 7 years. This has been the most effective collaborative response that we've achieved as a system over that time. Through our ICB leadership, there has been a lessons learned process which has been started, and certainly speak to my counterparts across the road in the Acute Trust. There's a real determination to use that to systematise some of the things that we did at pace. Actually, how do we build that into business as usual? And also remove it for the need for it being person dependent and really make it part of our regular systems and processes.
I'm grateful for the feedback I received from neighbouring partners, but actually the heat of the moment or the height of battle, whatever it is, however you frame it, that collaboration worked extremely well. So thank you. Sue.
Yes, so echoing what Anya said about it's great to read about the successes. Just to think about some of the concerns that have been raised in the past. One is that when we are, for example, in gold and everything is working towards one pathway, which is to relieve pressure on the acute, that sometimes people are being drawn from more routine but very important health support, or for example, transport no longer is enabling people to get to places because it's all having to be diverted. So maybe some reflections on that. And then also just potentially, because there is this need for bed management, have you seen instances of people being moved out and then having to come back quite quickly because there was a sense that we needed to move people on?
So there's multiple questions in there. I'll pick up first the first point and focus perhaps in on our neighbourhood teams. So we've got fantastic teams in the community who are juggling multiple priorities, and obviously this time of year everybody understands that we do need to support flow, and as always they stepped up and delivered amazing results, but that does also have the impact on the routine work that they're doing, and it's the reassurances that I can provide those teams that we're very much hearing those concerns. So in terms of the kit, the data, the prioritisation, the variability of the services provided in each neighbourhood area, we've very much heard those, and those will be forming part of transformation work as we go through this year. And those teams will very much be involved with that work. I think in terms of the bed management piece, there's a mental health piece there, and there's a physical health piece there, and it's people will inevitably go back into the acute environment from whether the community environment. That will happen at times, and it's about really getting to the point where you're taking the right amount of risk to support the journey, and understanding what those risks are and how you manage them. I think I'm probably stepping out of my comfort zone. That's it. So,
well,
thank you. But yes, acknowledging. I'm going to hand over to you now.
And I think it's really difficult, isn't it? So that stepping down of the prevention work, you don't often see an immediate consequence of doing that. So it's how do we track that over time? But I guess for me, there's a couple of other things about patient experience and patient safety that creep in. One, we'll manage that through our incident framework. So those lessons will be learned very clearly through those. When we start to see themes coming out, that will start to show. There is definitely something around patient experience. So we were really interested at Hospital at Home yesterday around, well, actually, the staff are prioritising, but also how does that feel as a patient? I think I should be in hospital, but you're sending me home much earlier than I think you should be sending me home. And the carers that are in the home environment, well, you haven't prepped me, and now I've got a very poorly patient coming home that I'm going to look after. So really making sure that we view it from all those different layers of patient deterioration. We haven't seen any concern in relation to people having to go back into the acute when they've been discharged to a community hospital. We haven't seen people going from Hospital at Home back. So that appears to be robustly being managed. But how does that feel as a patient and a carer would be really, really key, I think, as well.
Yeah, I just wanted to add a thought. And I think it's really important for us as a board to just reflect on for a moment. And I'm not picking on you, Sue, because you happen to mention it, because I think this is language we have used. We're not supporting the acute trust with their flow. These are our patients where we have a surge in collective pressure. And so it is all of us trying to do our very best endeavours to move patients through our system in a kind of more rapid pace. Because I think there has been a bit that kind of, oh, we're helping them again. No, these are all our patients and we all have that responsibility. If that ambulance can't attend the person in the community waiting for the CAT 2, we own that as much as they own that, we all own that. So we've been trying to really be clear about that positioning. And I think also, absolutely right, we must think about sometimes when we move people through at pace, there are things that get compromised around some of the time people might have, some of the communication, and we have to be really careful about that. And I did see one incident yesterday of the example where we can see a discharge happened at a time of day that wasn't great for a person who was vulnerable, and we will learn from those. But I equally heard examples of, and when I say we, I mean the system, that was someone who came to us and the neighbourhood team are saying, this feels a bit suspect, let's see what we can understand about that. But I also saw examples. So there was one where Sue took a difficult decision the second weekend about a bed in a space that wasn't ideal in a community hospital, but was somebody who was end of life, and it would have been even less ideal for them to find themselves in a busy A&E department. So I think I'm really assured the team are really live to that, and trying, but we're sometimes in that least worst, aren't we, in some of these moments? And I think we just have to acknowledge that. But definitely, we did better between the second week and the first, because we learned things and we had a more stable weekend in terms of still delivering under pressure, but it being more planned. And there is definitely, Scott and I have had a number of conversations, as he said, with my helpful reflections, that there are things we could have planned to do in November, which we could have given us a more, perhaps a calmer feeling of expectation, rather than having to pull quite so much in at the last minute. But it really was a phenomenal effort under pressure. And I think the joint working has really taken a step forward. And some of that repositioning, which is why I just wanted to put it on the notes for today, has been important in that piece as well, I think, that we're all a system team in it together.
Yeah, no, and I think you're right to pick up on the language. It's not a hierarchy, it is all working together. So yes, thank you for that correction. Yeah.
The NOC is going to be a strategic issue for quite a long time, and I get very much that we, as a trust, need to be in segment 2 as quickly as we can be because of an impact on it. But the question relates more to what particularly the exec team's perspective is on us sitting at whatever we are, 30 out of 60. So we're mid of the pack. Does that matter? Is that something we're giving active thought to? have we a strategic priority to be in the top 10, say? And if so, how would we get the data that we need to do that?
So I think, okay, so again, it's quite a complex question that I think that the absolute priority is to be able to give the best possible care to the patients we serve. And actually, the metrics which have been selected for the NOF, they lean into areas which demonstrate how well we are doing that. So I think that's a really, really important connection there. It also does really reveal the areas we need to work on. So in terms of the access to services and the long waiters, and our staff, so around staff engagement and our staff sickness. Now, those are all things that are really important to us about keeping our staff well and making sure we're providing patients with the best possible access. If we focus on getting those two things right, and like I said, I'm hoping for some positive bits and pieces about the staff survey, and that'll really, really carry the cultural journey on that we've been on, but also we'll start to see that movement. Personally, and I think obviously it was a question for the executive, so I'll open up. But personally, for me, it's the if we move up in segment 2 or who knows even further, it really speaks to us achieving those goals around quality of care and making sure we're taking our staff with us and creating the environment where they can deliver the best possible care.
Yeah. Shall I add a thought?
Yes.
Yeah, I mean, I think it's a great question, Colin, and I think I don't think any of us are happy to just sit middle of the road. I think we need to have more of a focus on the granular points that will improve and move us forward. And, for example, the piece we've put in here today around the waiting times, we're all clear, all of us in the executive team, that is not good enough. And I think the important thing now is how do we get a trajectory, but also the visibility and the acknowledgement here in public. That is not good enough. We're not content with that performance. So, but we know that isn't going to be a 5-minute job to crack it either. So then I think it's about being accountable for the improvement plan. Because one of the things I will say about the NOF metrics is, you could look at that, and I forget the very exact figure now, I'm just going to look at it now, but you could look at the, 2.3 point something, 2.02 and think, is that a big move or a little move in the patient access score? She says, when diligent isn't very quick. You could look at that and you could think, oh, well, that must be a very small change because they're quite hard to discern what's underneath it. And then when you actually look at the data behind it, that's telling quite a significant story, actually. So Scott has already referred to this as a report in evolution, but we are looking, the conversation we've had, just to share that with you, is we want to have more of that crunchy data so we can see what actually it means behind the NOF, so we can have that clarity. And then I think probably also add some of the things that are important just to us as we understand our delivery plan against strategy. Then we may have other metrics in our integrated performance report that go beyond the NOF, but will take a bit of time to work. And I think that's a conversation for all of us as a board to have about where are some of the things that we particularly want to focus on, what's important to us.
I think just to also add for me, having a strategic intention just to improve on the matrices is not sufficient to move the NOF segmentation. I think we need to improve better and faster than other trusts, which is going to move us. And I think we need to embed that dynamic into our improvement plans.
Any other questions? Scott, thank you. It's obviously there's lots of stuff in your report demonstrating that there's areas that we need to work on. Thank you for for outlining that there's plans afoot. Looking forward to receiving reports on how those plans bed in. I guess my question is, you talked about the 2 plans specifically in respect to waiting time. Is there anything more we can do to help the pace at which we can deliver some of that improvement?
Yeah, so there's a lot of moving parts there are in terms of the work we need to do here, and the starting point is that joint vision with commissioners about where we want to get to, and that's really critical of what the 3-year plans deliver. And our commissioning colleagues have been, you know, obviously it's a very fluid environment there, but they even, just as we've put lots of effort into that, they've put an awful lot of effort into it. I do though think that there's other things we need to reflect on as well. So really listening to the patient and carer voice. There is something around no wrong door. There is something about navigation, particularly children with the most complex needs, and these are things that myself, Natalie and John have spoken about how we can start to create that as we go into next year or next financial year with some of the transformation work we need to do. And I think it's really listening to that voice will really help guide us through those processes. I do with Natalie and John there. Do you want to?
I completely agree with everything you said, and I think the question is there anything else we could be doing? I guess for me, we mentioned it earlier with the patient story. Digitally, we're quite far behind, so a lot of things that would really enable us to be pacier, better, more quickly, are technical solutions. So how we then work with more pace around those is, I think, our challenge to ourselves. And we have one example this morning. We think we can make a decision faster with a bit of risk, which is the right risk to take to make the improvement. So that's the key area I'd say we could focus on.
Good, thanks very much indeed. Folks, we'll go into the finance report. Robert.
Yes, thank you, Chair. We've got the month 8 finance report here. We have actually just concluded in terms of month 9, and I'll just out from there is nothing coming through from month 9 to change what I'll say today. But just in terms of what we've got here in the report, a few important areas just to draw out for you. So just from a revenue perspective, I think the first thing, the most thing is the underlying run rate remains actually stable. We are tracking to deliver the exit run rate at the end of this year will put us in a good place for next year. Clearly, there's a lot of work going on around the financial plan for next year. That's not to downplay how much work is still to do there or how that's going to be. But one of the key risks we would have if we have a run rate that is not where it needs to be as we go out. So that's testament to all the hard work that teams, staff have been doing through the year to get us in a good place to run forward. So that also throws through that in our position at the moment, on the wrong plan, and also there are risks to delivery for the remainder of the year. We are on track to deliver forecast to deliver our plan for the remainder of the year. Draw out the key points in that, though, things that we look at and what NHS England look at. Really a lot of focus on temporary staffing, and you'll notice we've got the continuation of the theme we've had through the year. Some really good progress overall. We're on where we need to be on temporary staffing. Better progress on agency, on bank, which is probably what we expect, and just reflects actually there's been both an element of swap out to lower cost, as well as an overall view of do we need that additional capacity. So the two things from there. Temporary staffing remains one of those key features of all NHS plans for the next 3 years, and try to continue to bear down on that. So a lot of work about how we continue that into next year, and more no doubt will feature in our plans that come forward in March. Just in terms of efficiencies, that's clearly one of the other key pillars that organisations need to make progress on. We've got a very challenging plan for this year, 13.5 million. What you'll see is actually we are substantially ahead of plan. That's really due to a timing of some non-recurrent efficiencies. So there was a 1.8 million of the plan that we needed to do, but non-recurrent through a various set of measures which we've identified and actually we're able to release that. So that's why we're ahead of plan. On the forecast, looking through, there's still a few areas that we're just trying to make sure we finalise delivery. There's a few areas Scott helpfully talked about, fantastic work from our colleagues in both community hospitals and mental health environments, and work on length of stay and how that's improving productivity and efficiencies. Clearly, work to do to make sure that stays embedded. We put that through, but those are there. So efficiencies looks good. Again, it's critical that we have high delivery in terms of recurrent efficiencies, as opposed to just non-recurrent, because that's the bit about how we draw into next year with an underlying expenditure run rate. It's going to not give us a nasty problem to overcome. So that looks in a reasonable position at the moment. Then just a couple of other bits I just want to draw out. So I've periodically touched on this as I've presented over the years here. I'm really pleased to report that we still continue to maintain our Better Paper Practice Code, which is really important to us as a major employer, major contributor to the local economy, that we are paying our way in a timely way and supporting businesses. So that's important. The cash is moving. And then just to touch on capital, which obviously is a really important area for investment in our infrastructure, enabling support, equipment, and the like. That is on plan. We've got a couple of major projects that concluded this year, you'll recall, but we've also got a number of things that we need to get concluded by the end of the year. We're a little bit behind in terms of phasing. That's mainly due to go through procurement and then get suppliers mobilised. But we are fairly confident that we'll deliver the plan by the end of the year, as agreed at the start of the year. And that's the summary, Jen.
Any questions for Robert? Very clear, Robert, very clear report, very clear position as well. I don't have any specific questions. Thank you. Good. On to the priority programmes.
It's only a quick intro from me. Obviously, we've got focus on temporary staffing, which Natalie would on. Just to say, though, that the priority programmes have obviously all been assigned to the committees, so they've all gone through that cycle in the last week, 10 days, and the assurance is obviously in the assurance levels are in paper. But just to note, the EDIE standing out as a 2 reflects the reset of the work programme. So we've been monitoring ourselves against the high impact actions, so the 6 national high impact actions for EDIE, and we've reset the focus for 26-27 very much on inclusive recruitment. So the whole action plan. So it's actually more at the point where we were working that through to sign it off. That's why there's a 2, though. That said, the area for us, and we need to make sure that we're monitoring that through PCC robustly. So that was really what I wanted to say about the overall priority programme status. We didn't have programme management board in December because of Christmas, so working through the paperwork for that for January, the committee cycles. Then over to yourself, Natalie, if people haven't got any questions for the deep dive.
Before we go into the deep dive, Erin, you're absolutely right. The thing that sticks out here, obviously, is the EDIE programme. When do you think board can expect to hear an update on that is substantial in respect of the recovery, and we can start seeing a direction of travel that we feel is positive on this?
In the next reporting cycle, the work's active now. We're doing some, obviously being involved with some of the staff networks and the conversations we want to have there. There's the refresh against the high impact actions. We've been doing some work with our acute colleagues on the anti-racism charter and add that. So there's some real pace. It just needs to now come through and be very visible at the committee. Yeah.
Sorry, Natalie, over to you.
Oh, thank you very much. So I'm just going to do a brief overview of the temporary staffing programme. Thanks to our previous coup, who was the SRO, who I took over from. He laid out some brilliant groundwork that I took over. So it's, this is thanks to the team who'd already started working on this. I just want to guide you through what are called control measures. So we had a number of what's called control measures, but in my eternal optimism, I'd like to call them measures of success. And they were the areas that we wanted to look at that would really define how we could reduce agency and bank spend over the year. So the first was no off framework usage. So previously we had been a very high use of off framework agency. We were a national outlier in that. And that's been a great success, the work the wards have undertaken specifically. And we have had no off framework usage since the 1st of April 2025, which is brilliant. I want to thank the wards for that. The second is that any non-ward area should only be using bank. And again, we've made great improvements on that with a couple of exception areas. And again, we've enabled a process where if that looks like that needs to happen, that's signed off by myself with some oversight. And that helps in a number of ways. One, it gives more grip and control about how that's managed, but also it enables the team to really then talk through the challenges they're facing and how the execs can maybe support some different solutions so we can get back to a different place and of them not requiring agency. We now have a really robust process around long-term placements where we need additional staffing on a more consistent basis, either through bank or agency. There is a national requirement for no band 2 or 3 agency use by January 2026, and our programme of work was really impressive in relation to month on month making improvements within that, and we believe that we won't have any concerns with that moving forwards. And then the final one was around wards managing within their establishments. So we've done the background work around what your establishment is. We've got a really robust safe staffing protocol, but now how do we really enable teams to work within that resource and minimise the use of temporary staffing? We mop up the end of this financial year with a workshop at the end of this month to review what's gone well, what could have gone better, and then to set our measures of success for 26-27. It's going to be a challenging target for next year. And I think we already have identified there are a couple of real root causes that we need to tackle as an organisation if we're going to be able to succeed. For example, the main 2 reasons of usage are vacancies and therapeutic observations. So how, if we can, it's vacancies, sickness and therapeutic observations. So we need those 3 areas to have some real focus energy on them for us to be able to impact change. And that's all I wanted to say really today.
Any questions?
I've got a very general question about the assurance level of the days. That you did, it's 72 on diligent. It's a helpful summary. And although I understand the reasons for this, in stark reality, it doesn't show the best picture because there's very little positive nature. When you look at 4 or 5 priorities, so we call them priorities, but the reality is they're not moving. I just wondered if there was the need to have another look at that and think about the story it's telling us.
Yes, I can back to on the overall report. So I agree, and I think often we're really harsh on ourselves. So, for example, I could talk about the temporary staff reduction programme has seen an improvement, but that actually took quite a lot of challenge for us to change our assurance rating. And I do think we're really self-critical rather than sitting back and acknowledging we've made significant improvement. We weren't still a 3 or a 4. So I don't know if you want to talk more broadly.
And I suppose just to reflect, some of this is because we didn't have PMB detailed conversation where we may well be able to get underneath the bonnet of what some of that shift might have been. At the committees, I'd agree. I think we are often setting a kind of more cautious approach. We did that around the culture score in particular, and actually when we did the dive, we were more happy to move it on. So I suppose a challenge to us all to be looking at where that movement is happening, and if not, then obviously the whole PMB needs to go through the action planning, the timeframes, and then the PMO to drive different conversations if we don't think the traction we need.
And if I can just come back in as well, I think the other thing we get much better at is describing what the outcome would look like. Yeah. So what is it that we are a 7 would look like. And so, and I think we talk about actions a lot, but not outcomes. I think that's something we can improve.
Richard, I think that's a really helpful response, because that's what the whole process is designed to do, is to get outcomes, and then so focus more on that.
Well, Natalie, my colleague has actually said some of what I was going to say about, I think we sometimes are measuring ourselves in activity done and inputs rather than outcomes. Said it already, Natalie. And I think I'm going to put myself firmly in the middle of the road. I'm not sure which side I'm veering to about the use of the kind of definitive number assurance rating. So I think we need to do some more work to test that and whether we think it's working for us. Yeah, and whatever analogy you want, middle of the road, on the fence. I'm here to be persuaded whether it works or it doesn't. But I think we could do with doing some joint work to really think through whether it's serving what we need. Because if you're always putting everything in the middle, it's not really telling you anything, is it? So I think that's TBC, isn't it?
I think also, dare I say it, I think we go into reading something like this with our eyes wide open, in that it is the detail behind this that matters. This should give a very transparent and honest position. At the same time, I think it's really important that we always digest the detail underneath it. Be open to challenge around where things are not working, and all seek to figure out how we're going to make those improve. We know Colin and I know, and some of others, we've spoken about this on numerous occasions. So really welcome, as Colin said, your response on that. Thank you. Anything else for Sue and Natalie? Great, thank you both. We're on to the governance aspect. So Beth and responses.
Okay, so I don't want to say a huge amount about the BAF report this time. One of the reasons I don't want to say a huge amount about it is that at the moment, this is still a report that kind of goes as is from committees to boards. So I know you've done much more of a detailed look in committee. And our ambition for the future is that we're really clear what value add is of bringing it at the different tiers of our governance. So I think, and also the other thing to just flag is that I think this is probably the last time we'll bring it in this format with one of the projects that I've given. Sean is to do a thorough review of how we're doing this reporting. So what we plan to bring in the next cycle will be more set of proposals how to take that forward. And there's something for me about how we maybe broaden our lens a little bit more of our aspects of our business, as well as the strategic aspects of our business. But that, I don't want to spoil too much. Just to give you a little trail. But I'm happy to take any questions on the report as is. But otherwise, my assumption is committees will have done deep dives into that.
And those around it, sorry, go ahead, Carol.
Just a quick one. It's an assurance on assurance, because I note that under objective 4 and 5, it talks about the Mental Health Joint Committee as part of the assurance. And we will be picking up on that later on, because it was originally on the agenda, but it is meeting and it is looking at those things. So that's assurance on the assurance.
Brilliant. Thank you. Try and minute that one.
Yeah, and as Sean, as you progress with that work, any input you need from those that may have a view on this or wish to add, then please feel free to speak to Sean.
There'll definitely be a board workshop on this as well.
Good. Okay, thank you. And the next one's also with you, I think, the managing conflicts of interest.
I'm not proposing to say anything other than to note the report, and if anyone has anything they want to raise or ask a question about, but I'm going to assume members have read the report. It's very straightforward. It's a requirement to just share this in our blue papers. I have nothing further to add.
Are there any questions on that, or is everybody happy just to note that on the basis that we take it everybody's read it in detail? Okay, thank you, Ellen. I think on the agenda we've got a comfort break about now, so let's take that for the next 10 to 15 minutes.
Yes,
Yeah, or Bath, can you confirm this is off?
The vote changed, but
Yeah, all good. Mute's off.
Yeah.
Right, folks, we'll make it start. Okay, thanks for making hang on time come back. That's good. We'll go on to the assurance report and the committee report. So firstly is Onyi, quality safety report.
Thank you, Chair. I think before I start on the report, I just want to inform the board that we welcomed our two patient safety partners for the first time, Tina Knight and Batosh Bileski. And they joined our committee meeting this January, and going forward, they'll be attending the committee and also the Learning and Improvement Forum. Their involvement will strengthen our patient voice, our learning and co-production, and will also help with our quality governance. So that was really welcome. So moving on to the report from the committee, obviously we are a committee that will provide a forum to gain assurance on our quality and safety performance and any emerging risks. With that in mind, the key emerging risk that we would like the board to be aware of relates to our children and young people services, and this came up through the integrated governance route, and it's specifically around the capacity for us to be able to undertake the physical health checks for patients that we prescribe ADHD medications for, in line with the NICE guidance. So while at the moment we have interim mitigation plans and we also are developing longer term solutions, however, current demand significantly exceeds available capacity. So this is going to be an area that quality and safety we're going to keep under review, and we will escalate it as needed. In terms of assurance, we reviewed the internal audit follow-up relating to consent to treatment. In the past, or last year, was an area where we received weak assurance. However, the committee can now assure the board that we now have significant assurance on the trust improvement approach with moderate assurance on the audit findings. So this actually shows demonstrable, tangible progress, but however, we still maintained it as a priority area for us in 26-27. We also looked at gaining assurance in terms of the annual resuscitation committee report, and it's demonstrated and improved compliance with both our BLS and our basic life support and immediate life support training. And we also gained assurance in terms of there was an audit activity that was done, and this has led to improved monitoring of our resuscitation trolleys, which is showing clear impact of what an audit, a strengthened audit activity can bring when it's used properly. So that's now going to hopefully give clear impact on quality and safety of care that we provide for patients and resuscitation. And we also reviewed an annual information governance report, which is attached for information. And following discussions and assurance, we moved the assurance up till 6, reflecting their strengthened controls and the improved organizational maturity within their report. And finally, the committee would like to celebrate the continued expansion of our quality, safety, and improvement training across the organization. We doubled the number of staff that have been trained from 135 to 256, which is a significant step change in building improvements at scale. And we're hoping that this investment will now support our staff with practical improvement skills, and hopefully is also a strong enabler for sustained improvement for quality and safety. So we're really proud of that. And open it up to questions. Any questions?
Very complete. Thank you. Thanks very much indeed. We'll go into the next one, which is People and Culture Committee.
Okay, thank you very much. So I'd like to begin by thanking Vina in her absence for all the help she's given me in understanding the journey that the committee's been on, and obviously Onye and Colin as well as members of the committee. As we've heard from Scott, Rob and Natalie, one of our key priorities has obviously got to be on ensuring that our staff are able to be working. And that, as you would not be surprised, was a key focus of the meeting. So we were aware that our NOF score for sickness absence is not where it should be. It's in quartile 4, and so the board won't be surprised that, you know, our sickness absence recovery plan was the main feature really of our meeting. We had a plan presented to us, which would include 3 phases. It would involve bi-monthly monitoring, and it would be supporting our activities to meet the national objective, really, which is to address sickness absence across the NHS, with actually the timeframe of 2035 when there is a final a target figure. We have done quite a lot of work in the committee, and we've now been given post the meeting an updated plan, which we're going to look at as individuals, really to address what we can do. We looked at data involved, which showed us what the absence was and the reasons for absence. And we talked about ways of supporting staff and staff teams to help when there are issues of sickness absence. We talked a lot about the triangulation of information that we get from a number of different sources, such as exit interviews, sickness rates, to see where support can be best employed, and also to celebrate where teams are having very high levels of presence at work without necessarily wanting to encourage, well, of course, not wanting to encourage presenteeism, because we recognise that one of the dangers of having very high or very low absence rates might be staff who are present but actually are unwell and or not being productive, because in fact their circumstances in which they're working is not allowing them to take the time off that we know staff will need from time to time. So it's a very fine balancing act. It also requires quite a lot of empowerment of leaders to know how to support their staff, and I think that's really where we'll be moving the dial in the initial phase of the plan. So that was, you know, a significant part of the meeting. Otherwise, we did hear back from our subcommittees. So we have subcommittees, our 3 priority programmes. We talked a little bit about the overlap between those programmes. We did a bit of ratification of policies. So we ratified flexible working policy. Obviously, that's again key for the health and well-being of staff, to know that they have got access to flexible working practices if that's what their lifestyle requires. We also looked at the security policy and the violence prevention and reduction policies. And we were very aware that one of the 4 major reasons for people not being able to come to work is stress and anxiety. We talked a bit about the contribution of those policies to reducing people's stress and anxiety to work. We wanted to celebrate finally the fact that our offer to you is very, very strong in this trust, and we said that sometimes not everybody is aware of exactly what that entails. And one thought about the visits that we go on might be to talk about whether staff are aware of our offer to you, whether everyone on the board is aware about it when they go, because actually we do think that we have many things in place to make us a very good employer, and those are things that we want to really celebrate and highlight to staff.
Any questions? Any questions for Sue?
Really, just to reinforce that last point that Sue mentioned, I think Bijou and I have had a conversation about whether we could actually be very clear about our wellbeing offer for staff, include that in one of our development sessions, because I think it's more detail out there than we hear, and it is good. And if we know what it is, then it's easier when we're going out and about.
That's right.
I'd take 2 actions there, please, Bijou. Or looking at the offer to you being included maybe in the remodelling service visits, and the second one is just acknowledging that development session.
Thank you. Anything else, Sue? Well, good. Thank you, Sue. And I'm glad that your first meeting chairing that committee went well. So thank you again.
Well, I hope so. And I'm very, very grateful, obviously, to Sue, all the work that she's done in this area with her directorate, because it's clearly a very proactive area of the trust to be working in.
Good. Okay, Finance and Performance Committee report. That's with me. Looking around the room. I take it that you've all had an opportunity to read the report, so I won't go through it word by word, but certainly there's some things that clearly, I think we've already mentioned implications, strategic implications of the NOF, and I think that's the only alert that we've mentioned in this section on the F&P report, because of the implications of not keeping up with maintaining, but more importantly, improving our NOF standing. We had a broad discussion on it. I won't go through that again. The things that really jump out to me in terms of some of the things we heard at committee. Firstly, the estate's utilisation. A really thorough piece of work done by the estates team with Martin Jones's leadership. And clearly now, actually, the benefits are in what happens next. But the work itself has been very detailed around our full estate and what needs to be done next in respect of more effective and efficient utilisation of that. So I'm mindful that actually we'll probably see progress from here on in, and we'll report accordingly. The other bit that really jumps out for me that we talked about was Talking Therapies Recovery Plan. That there are, as you'd expect, a bunch of national metrics and measures that we need to adhere to when it comes to this. It was pleasing to see the report talk directly to how we're going to meet some of those national metrics. So again, thank you to Dom for his leadership when it comes to Talking Therapies and the detailed nature of his report that he brought to us, recovery plan, which we all signed off and approved. I don't have any other specific things to call out on the report. Anything else there, but I'm very happy to take questions.
Observation, on this one. I'm glad you raised the issue of the estate's utilisation, and I think that is going to potentially yield a lot of significant benefit. But it struck me in the report itself that the issues that we have to address are not just bricks and mortar, but the behavioural. People's working space is very valuable and a sensitive issue, and so some of the changes that we propose to make may well have repercussions. So I, like you, look forward to further reports, but I don't underestimate how difficult that presentation might be.
And there's probably something in it in respect of how we make sure we collaborate with the People and Culture Committee, because it is, you're absolutely right. It is, it's interesting to see some of the practices, people and their behaviours as you wander around the estate and you do service visits. And there is a need to make sure that there's a more collaborative way in which people work when it comes to our bricks and mortar. You're absolutely right, but that's in hand. Any other questions on finance and performance?
Yes, Mr. Chair, if I can make an observation in terms with my new risk management hat on, I think the way this has been formatted in this report in terms of looking at the way the committee has looked at risk and issues and given an update, I think is to be complimented. So thank you for that. I think my observation would be it would be really beneficial to see that those updates may be coming through the other assurance committees. I think it demonstrates a good risk appetite in terms of finance and what we're doing there. And I just think it's a really good area of improvement and learning in terms of doing something through the other committee assurance if we can.
I'm going to tag it on to the back of a conversation we had preceding the board meeting, where a number of us met and talked about, how do we improve our ability to talk to assurance more consistently, the layout of this report, what does alert actually mean, etc. So if I can give that action to Natalie, Sue and Robert, who are going to follow that one up, and perhaps ask you to look at that as well. But great, thanks. Good. Any other questions? Perfect. Great. Okay. Audit committee report.
Just a couple of brief items on the science from the report. Under the heading Assured, you'll note that we approved the external audit plan fees and the plan itself for the forthcoming year. And it's interesting that in the external auditors give us a heads up effectively the sorts of areas that they're going to be focusing on. And as it says in the report, strong governance remains critical to mitigating the risks that they've identified. So it's no great surprise. We'd expect to anyway, but we need to be very aware of the sorts of areas that the auditors are going to be prepared. Under the heading Rio, just to comment on the fact that the technical issue of the accounting treatment in respect of the expenditure we had on Rio still is moving forward. We're not quite at a resolution yet. There's no cause for alarm. Robert and his team have done some really sterling work looking at what we spent money on and putting realistic and well substantiated case forward for the accounting treatment adopted. The external auditors have been a little reluctant to totally sign it off, but I think they're looking at it with realistic eyes. So we don't expect any further difficulties in that area. Safe to say that this is an ongoing issue for the whole of the NHS, as I'm sure colleagues are aware. The whole question of how you can invest in the digital agenda, but you're not really able to put it into capital as to come to work. That's a fundamental issue. It's one that we've got inside, but it's worth keeping. I think that's all, Chair.
Any questions for Colin? That hand up, Sue, I can't see.
Well, just on that last point, because obviously we've talked about the different things. Is there a way of the audit committees on lots of different trusts talk to one another to say that this is a problem that we need to escalate? How is it ever going to be resolved?
Fundamentally, it's an accounting standards issue and interpretation. So it's down from DHSC down through HSE. And it's about the adoption of a particular standard, which over time, the parameters around how it gets applied their own. The standard was 2021. So in terms of nationally, they are very aware of this issue. But the reality is what we would used to do around intangible assets, software and so forth, is not going to be acceptable to take it through a capital route. It is a revenue route. It's kind of a grey area depending on how customised the bespoke the product is. But that fundamentally isn't an issue for trust to lobby and change. It's about actually how funding flows are, just to recognise that. That's a national discussion. Everyone's well aware of it, but it's something that is kind of evolving to go forward. The reality at the moment is because I guess negotiations for funding tend to happen, there's still kind of a bit of a lag. There's capital funding available for a number of things which are probably now go through a revenue route. So it's something that national policy just needs to move at the time with that, and ultimately negotiations with the Treasury around spending settlements.
It's certainly a live conversation when I speak with other chairs, because everybody's sensitive to it. And SaaS is just software as a service and how it's treated from an account. It feels a bit, computer says no, but at the same time, it's very understandable because accounting standards are there for a very obvious reason. But let's see how that goes. Keep us updated. Thank you. On to charitable funds. Sue.
Yes, so there is nothing in particular that needs highlighting from this report. You can see that our investments are doing well. We constantly ask whether that's going to change, but so far we haven't dropped off a cliff. You also see that there's mention of a legacy that we're expecting. There will be some limitations around what we can do with that legacy, but again, it's very welcome. And we're very grateful to the legator for thinking of us in their will. So hopefully charitable funds is able to meet the demands that I know are increasingly put on it when people are looking for sources by which they can undertake work which might not be otherwise available. And certainly, again, when we go out on service visits, it's very good if we can highlight the ways in which people can use charitable funds to support their work. Recently, for example, we've seen the impact at Osborne Court of the charitable funds support for an outdoor playhouse, which helped meet some feelings that we needed to do some more work there on the part of external agents. So that sort of thing is what we really want to do.
Thank you, Sue. No questions? Thank you. We'll go on to the ICT strategy annual review. Rob.
Yeah, thank you, Chair. And I suppose the first point is clearly the context here that digital has featured in lots of conversations this morning, isn't it? And actually, there's a fast-moving agenda. There's national ambitions around that strategic shift from analog to digital, and we've talked a lot about how there's things that we need to do better, adopt earlier, and kind of remove some of those barriers. So, notwithstanding all of that, I guess just to pick up where we are in terms of the report we have here, which I think is quite timely to a degree, because this is actually the report on our strategy, which we set 5 years ago as a trust. And a lot of that was about renewing our infrastructure, looking at our EPR system, looking at our newly insourced services and making sure they're responsive to what the needs, wishes of our staff were, as well as our partners. And there's clearly been lots of really good progress there, and the report draws that out. I think it's actually a huge credit to the team when you look at it. We have deployed a new EPR system just over the past 18 months or so, 2 years, a lot of work around that. And there's plenty of stories across the country of new EPRs going in and all sorts of problems arising. So the team, incredible job in terms of engaging with our staff and so forth to get that system in. I guess the challenge as we go forward is how do we leverage the benefits from that? How do we really get that as a opportunity for us to think about how we get services with better care, for better experience, and also reduce costs? That's one example. We draw out the things that we put in. So better meds is probably another example of something we put in about a big change. Just drawing from the report, I would highlight, I know the team are particularly proud of this, some of the advances that have been made in terms of the support to our trust, the help desk, the accreditation, recognition of what they do. Some really good work there. And there's also some reference to some of the early work we're doing around AI and how that can be used, and kind of how we can think about how that can make life easier for our staff, as well as make the experience better for our patients. So there's a lot in there. I'd also draw out, this is going to be a point of focus for our new director, which Helen talked about at the start. So the key points I want to draw out, there's lots to celebrate there in terms of good progress. The timing point is 25-26 was actually the final year of strategy. We're 5 years in. Work is underway. I think will be a key focus point for our new director when she joins us, to try and draw some of this together. And at some point later in the coming year, I think we'd be expected to see the new strategy coming through, which will hopefully give us the opportunity to align with the trust strategy, and particularly drawing out national context around how we're going to make that huge shift from analog to digital, use the opportunities that we have here to drive some of that transformation, innovation, productivity, better quality of care, good patient experience. That was all I wanted to say. To come in questions.
Just a comment really. When I first joined the trust, it seemed every time you went to service, what you heard about was digital, and it's no longer the case. And I think that's great that you've got the 3-star rating And you know, thank you for all the work that's gone in that area.
I'd love to take the credit. Clearly, did some sterling work in driving that board.
I know that we're looking at the report specifically, or the strategy, ICT strategy specifically, but I think some of those broader conversations and the themes you just touched on, which we've explored at F&P, such as AI and our ambition around digital, you know, I think we need to keep the momentum behind those conversations, notwithstanding the financial envelope to invest is tight. Nevertheless, I think, you know, we should always be prepared to hear stories about where sustainable returns for the organisation if we look at the technology, and we heard about digital solutions or the need for them earlier, didn't we? So that's expect that we continue to talk about that with some momentum. And of course, the pressure's on Gemma.
Television.
Yeah, and you know, I think most of you will know, but when we interviewed for the director, there was a clear focus on what's your ambition around this space. How does it fit into the 10-year plan? And what does that, you know, that journey look like? So rest assured, all candidates and successful one, Gemma, were agreeing on this. Was that a little hand up there, Natalie? Or? It's like being at an auction. Scratch your nose. It's like being at an auction. You might buy something. Yeah, you might end up buying something. There you go. Okay, right. We're on to the final straight, gang. Any other business? Carol?
Yes, please. It's first a little request. Mental Health Joint Committee was on the agenda this time, but if we can drop that in as a routine item. We have met on this occasion. And Sean, don't worry about writing down everything I'm going to say because it's all written down in an ICB highlight report, so I'll make sure that you get that. So the first point to make is that Sarah Raystrick, who was my co-chair on the board, is no longer a non-executive member of the ICB. So at the moment it's me. So I'm co-chairing myself, but Vicky Morris, who's one of the other non-executive members, is also on the committee and is a solid and sensible person for me to be able to talk to should I need to. The meeting itself on the 10th of December focused on the strategic planning for mental health services, as you would expect, across both counties, including governance updates, development of a refreshed mental health strategy, which is going to be in some sort of shape by July 26, medium-term planning priorities, and collaborative arrangements across the regional levels. And that obviously includes conversations with Coventry about where they're going with some of that work. In terms of system overspend, the Section 117 Section 117 costs are challenging, but we're working to deliver those. We're reviewing the terms of reference, yes, you might say again, and further work underway to clarify the remit, authority and inclusion about learning disability and autism oversight, because we've always had that at the side about is this something that we should be looking at or not. But we really need to bottom that out and know exactly what we're doing. So nothing to alert, and I've mentioned that the advisory elements, and I think just really to notice from the insurance point of view that to remind people that there is a mental health programme board that sits underneath the joint committee, and they've undertaken a number of recent approvals about digital interventions and alternatives to talking therapies.
Thank you, Carol. Any other matters that anybody wishes to raise in any other business? And just before we conclude, are there any matters anybody feels we need to escalate to any risks that we believe we may need to escalate? Good. Okay, we've got signature and sealing of documents. 2 of them are noted here, so forward to note. And there were no advisory appointments period of this board meeting. And finally, the date of the next board meeting is the 19th of March. For that, I'm sending apologies. I won't be, but Carol will be in the hot seat. That one. Thank you, Carol, in advance. I'm sure it'll go really well. Are there any? If there's nothing else, we'll conclude the meeting. Thank you very much.